My name is Matt Hadfield. I'm a attending physician and assistant professor of medicine at Brown University in the Legaretta Cancer Center, and I focus on early phase clinical trials and cutaneous malignancies. And I also have a particular interest in immunotherapy toxicities and improving patient outcomes with immunotherapy toxicities, which I think is very important for today's conversation. It is Healthcare Quality Week, and to denote that, we're talking about our own initiatives with respect to improving quality in the healthcare setting. And unfortunately, despite all of our efforts over the last several decades, almost half of deaths in healthcare settings are still attributed to preventable errors, which really hints at how important this topic is. And I am joined by Lauren. I'm not sure if you'd like to introduce yourself.
Yes, thank you. My name is Lauren Ghazal. I'm an assistant professor at the University of Rochester in the School of Nursing and an associate member in cancer prevention and control at the University of Rochester Wilmot Cancer Institute. I'm also a family nurse practitioner by training in primary care, and a lot of my work has kind of joined nurse workforce issues and adolescent and young adult cancer survivorship. I was really excited to kind of join this discussion today, just on both of these lenses, and then also really as a patient in our healthcare system too. And so turn it over back to Matt, and then we'll have a nice little discussion.
Yeah, no, and Lauren, it's so good that we can have this conversation today. And as I was thinking about healthcare quality, and errors, you reminded me of this when you said as a patient in the healthcare system, because one thing that I think as I go through the hospital and go to work every day is when you see tired physicians, residents, nurse practitioners, nurses, anyone really coming in and out of the hospital, you think about what a strain there is on the healthcare system. And then I
Mhm.
always think, like, what if it was my mom that was going to the hospital, or what if it was my, God forbid, my one of my children going to the hospital to get care?
Mhm.
Like, is everyone completely devoted to giving like the best care, and is everyone being appreciated enough and taken care of enough to give the best care? And I think that's just another thing that always kind of crosses my mind when we talk about quality improvement. But I would love to hear about what type of initiatives that are going on at the University of Rochester.
Yeah, so I am still fairly new to the University of Rochester, but I was really excited about the Quality Institute that we have. And I've partaken in a few of their quality circles. So the University of Rochester Medical Center has a Quality Institute where they also have funding for small pilot studies or small projects that are really interdisciplinary in nature, to help look at quality improvement data within the medical center. And then they have these quality circles that, again, like I've joined a few of, they're really good informal conversations across different disciplines in the community where they can talk about issues related to quality care, projects, trying to brainstorm other projects too. And again, a place where faculty, staff, trainees, students can even just bring concepts about, I'm thinking about this, or in the clinical setting, I've noticed this. Is there a way that we can partner across the School of Nursing and the Cancer Center and the Medical Center, and even the Institute of Data Science, to be able to develop a proposal to look at these issues? And I think when we like a lot of my research in adolescent and young adult cancer survivorship has studied the patient perspective and the patient burden of financial hardship or financial toxicity. And I think that, we know that quality is linked to that because of the high cost of healthcare and this increase, cost bearing onto patients and their families. And so when we tie it back to what you just mentioned about, the providers that are navigating our care and, for patients, how are we making sure that we have a healthy and safe workforce, to be able to decrease, safety metrics like hospital-acquired infections and falls, and return on admissions, that we know are driving poor quality metrics and then also increased costs. So that's just a few things.
No, yeah, that honestly, there's so many things that you mentioned there that I think are so good to hear, because one thing that I've noticed a change, and I hope it continues to change more, is there has always been this kind of hierarchical model in healthcare where it's like, there's the attending physician, and then there's the resident physician or the fellow, and then there's the nurses, the nurse practitioners, and the technicians and the phlebotomists. And thankfully, I think we've gotten away from that in terms of how we view safety in hospitals and culture, and that everyone sort of has a voice now. And I think it's really made a big impact in how we incorporate, as you mentioned, at the University of Rochester, across multiple disciplines, getting everyone's opinions, including patients who have largely been left out of conversations for so long in terms of advocacy of their own perspective. We're doing a similar initiative here. So we have the Rhode Island Immunotherapy Toxicity Program, which basically looks retrospectively at data for all patients on immune checkpoint inhibitors. But one huge aspect of that project is looking at patient-reported outcomes, and particularly in symptom reporting, and hearing from patients earlier as opposed to when they come for their appointments, to hopefully predict immunotherapy toxicities, or diagnose immunotherapy toxicities earlier, to prevent hospitalizations, to prevent unnecessary steroids and things of that nature, because this is an area that's exploding. Immunotherapy toxicities is likely more prevalent than trials would recommend, or would make you think, and much more difficult to diagnose than I think we even appreciate after a decade and a half of experience with them. So incorporating the patient perspective, as well as everyone on the healthcare team, I think will make a big difference in trying to diagnose them earlier, and hopefully manage them better, because it's an area where we're really, I think, behind right now.
Yeah, and I think with what's fascinating to hear that too, have you noticed like any kind of novel metrics around quality or safety that are, need to be newly considered because of immunotherapy?
It's I'm glad you said that. I think it's hard, because some of the metrics that we use and have used in the past,
Mhm.
like hospitalization,
Yeah.
or repeat hospitalization, I think that's really hard with immunotherapy toxicity, because if you think about like colitis, for instance, sometimes those patients need to be admitted. So to me, you couldn't prevent it, or even if you discharge them and they come back, um, I think it's challenging. It's not like managing something like community acquired pneumonia or a STEMI, where there really is kind of a set, like, this is the course that should happen, and if we deviate from this course, maybe we're not managing it well enough, or if someone gets an infection, obviously, while they're in the hospital, that should be preventable. But I think with immunotherapy toxicities, it's just we're misdiagnosing a lot of them, and then we're mismanaging a lot of them. So it's really hard to like come up with the metrics of how do we do it better. And some of the ways that we've gotten around that is, how often are we grading them appropriately? So when someone has, for instance, pneumonitis, are they inappropriately getting steroids when they shouldn't be? Because the grade was actually, sometimes imaging looks worse than symptoms, and you can just withhold therapy and not give steroids. And as I'm sure you see all the time, anytime someone gets steroids unnecessarily, there's worse outcomes. So I think we're really trying to think hard about that. I would love to hear if the University of Rochester is doing anything in that area, because I'm very, very passionate about immunotherapy toxicities, because I think we anecdotally have been struggling at large academic centers for, again, since these have been FDA approved in 2011 for melanoma. And I wonder often, what is it like at smaller centers that are more resource strapped, that have less ability to diagnose and manage toxicities, but are giving immunotherapy every single day. So I would love to hear about the University of Rochester's experience with metrics, because that's something that we certainly are trying really hard to work on.
Yeah. Um, I probably not the best person to answer your question, but I can definitely find out more information. I think like a quick, I think in what I know about the Quality Institute, I know that they collaborate with other organizations like New York State Department of Health, CMS, and Joint Commission, to really monitor and report on these key metrics, or the clinical performance indicator initiatives, I think I've been told. And then, as you said, patient satisfaction scores. And so my question always is, in these quality uh, quality performance groups, or even within each organization, are there patient representatives on there? Are they kind of just aggregating data from patient satisfaction surveys or feedback forms? How
Right.
is that? Do you know how has that worked at Brown?
You know, that it's I think we're trying harder to think
Yeah.
about those things. And honestly, so and I always kind of talk about things from the perspective of immunotherapy because I work in early phase trials where pretty much most of the therapies we're developing have some type of immunotherapeutic component. And I do cutaneous malignancy where we pretty much give most patients immunotherapies. And one thing that I've really found interesting is that we oftentimes counsel patients on the worst toxicities that can happen. You know, you could develop pneumonitis, you can develop severe, even life-threatening myocarditis, but it's very rare, and most of the toxicities are manageable. But as we're starting to use these therapies more in earlier phases, so earlier phases, I mean, like the neoadjuvant setting, preoperatively, adjuvantly after resection. I mean, that's the wave of the future. We're going to start giving everyone immunotherapy with resectable disease. How often do they develop, chronic arthritis from
Mhm.
checkpoint inhibitors that they didn't have before? How often do they develop chronic symptoms, related to the immunotherapy that impact their quality of life? Because to me, we often don't focus enough on that, and those are important things that we should be counseling patients on when we give them therapies. You know, you could get a type 1 diabetes that, yes, is manageable, but although it's rare, you may be on insulin for the rest of your life. And I just think sometimes it's hard as a clinician to not be able to properly inform them. And I think hearing more from patients about their chronic toxicities that they've developed would be really helpful in measuring more and providing more informed conversations. Because I know many patients who have had cancer that's in remission for a long time, but they have like crippling rheumatoid arthritis now from a checkpoint inhibitor. And it's important to talk about because that is part of the conversation that goes into risk benefits for patients.
Yeah, yeah, yeah. I think about um, my own experience too. I was diagnosed as a young adult with lymphoma, and I didn't receive immunotherapy. I received ABVD chemotherapy, but definitely experienced kind of long-term um, paresthesia and numbness in my hands that there was only so much education I could have retained at that time of acute therapy.
Right.
And of course, I would continue to choose the therapy. um, but it's an interesting. I mean, as a researcher, right? I always think about measurement um, and this outcome of okay, quality and how that's linked to so many other things in the healthcare system that are really patient directed, patient driven, but then also patient perceived. And I think with satisfaction too, like there's satisfaction scores, there is some bias in some reporting. Um, and I wonder with quality too, and not as a quality scholar or as a researcher in quality, but how much of that is driven by like what are we even looking at with the final outcome, and how are we measuring that? Um,
Right.
I like I know Rochester, I know places I've been in the past, they've had like and I'm not going to remember the actual three questions now, but it's like, ask me these three questions. And it's really
Mm,
to like, what's kind of like, what's my main problem? What's the next step in this? And it's really trying to make sure that there is a central, and a coordinated understanding with patients and healthcare providers throughout all phases of their journey. But we know that now a visit is not just a 15-minute visit, and in primary care, it's not just a 30-minute physical. There are so many components of addressing social needs now and screening for social needs that all factor into high quality care. And I use air quotes because I still have a hard time really defining what that means.
no, absolutely. I think it's such a good point. I think one great big takeaway from our conversation is the patient's voice because, like you had just said, And it's so wonderful to hear about your experience, and so glad to be able to be here and talking to you about it today. Peripheral neuropathy, you would have still gotten the therapy, but and there is a level to how much you would have taken in during such a turbulent time in your life, and hearing all this information and so many things. But it's always hard to be the person prescribing things. And one thing that I've really thought about a lot lately is immunotherapy. I always feel like I'm like, I know about this, and this, and rarely I know about these things, but also anything can happen to you. Like anything
Mhm.
could, you could develop uveitis in your eye and lose your vision because there's case reports of that. And I like the amount of stress I feel like I cause patients, because you really are opening the Pandora's box with checkpoint inhibitors. I don't know what could happen. I mean, you likely statistically you'll be fine, or you might get like a crippling rheumatoid arthritis for the rest of your life, and we've cured your cancer. And I always feel like that's such a burden, because when you think about quality care, I think properly informing patients and shared decision making, and it's so hard to have shared decision making when we just don't know. We just don't know. I mean, it's a hard thing to sort of manage, and I always feel like I'm doing them a little bit of a disservice when I counsel patients on those toxicities.
Mm.
But I
I bet
think,
you're doing a great
yeah, go
job.
ahead.
No, I was gonna just validate you that I bet you're doing a great job.
I appreciate that. Um, no, I'm so glad we could have this conversation today. I think to wrap up, I don't know
Yeah.
if you have any final thoughts, but I think the patient voice is one that we don't listen to enough, and both being in healthcare, you know, oftentimes if you listen to patients, better decisions get made. Like, and I feel like that's something, we all struggle with the metrics and the biases, and are we measuring the right things, and are we making improvements where we should be. But if you just listen to patients, 9 times out of 10 things go better. I mean, if someone says that they don't feel like they're ready to be discharged from the hospital, there's probably a reason, right? Like there's probably something. Um and, and I feel like anecdotally, anytime I have listened to a patient and just taken their concerns seriously, it's always a better outcome for everyone. So I don't know if you have any final thoughts. That's what I was sort of
Yeah,
thinking
I
about
would
this morning.
echo patient voice. And then also, I think we touched on it earlier, but also ensuring that our workforce is kept safe and healthy to be able to deliver that quality care. Um,
Yeah,
there's more of
we
a
we
recommendation of that.
I don't want to end on a bleak note, and maybe I shouldn't, but honestly, like being in healthcare, working with a very very stretched thin workforce, I think we try as hard as we can. But when you think about the context of healthcare quality week, and 45% of errors are preventable. I mean, if you put that in the context of like air travel, if like a 777 crashed every week, like there would be congressional hearings, and there would be, I mean, so much legislature to prevent that from happening. But the fact that it's happening in healthcare every day, and some of that's attributed to, you know, nurses and technicians and physicians and APPs all working beyond their capacity and burned out and exhausted. We have to keep bringing it up because it's a huge, huge problem in our country.
I couldn't have said it better than that. I completely agree.
But there's a lot of hope. Like we're going to listen to patients, so there's a lot of hope. But I mean, there's a lot of work to be done too. So thank you so much. This was such a
Well,
great
thank you.
conversation.
Yeah, I know. Great to talk with you. And thanks for
Uh,
having us.
yeah, absolutely.